I'm Bernard Gersh, a cardiologist at the Mayo Clinic and professor of medicine at the Mayo Clinic College of Medicine. And I'm here to talk about renal artery denervation, the rise, the fall, and the potential resurrection of this technique for hypertension. The history of this goes back quite a long time. In this article by Dr. Esler from Melbourne in Australia, he states that evidence has been assembled in the past 3 decades, which indicates that sympathetic nervous system activation is crucial in the development of cardiovascular disorders, most notably heart failure and essential hypertension. And this diagram illustrates the effects of increased renal sympathetic nerve activity on 3 renal nerve effects, all of which are detrimental from the standpoint of hypertension. First of all, increased renal sympathetic nervous activity acts on the juxtaglomerular apparatus to increase secretion rates of renin from the kidney through the beta-1 agonists. Secondly, renal sympathetic nerve activity increases renal tubular sodium reabsorption and reduces urinary sodium excretion, again, a promoter of hypertension. And thirdly, renal sympathetic nerve activity acts on the renal vasculature to reduce renal blood flow. So it's quite understandable why modulating the sympathetic nervous activity to the kidney could result in beneficial effects on hypertension. The history really goes back to 1953, and this was a paper by Dr. Smithick, a surgeon, who developed the technique of splanchnicectomy or complete renal denervation for essential hypertension. And in fact, it was extremely successful in lowering blood pressure, but the side effects were intolerable, including impotence, severe orthostatic hypotension, and really mitigated the widespread adoption of the technique. Clinical evidence of a reduction of sympathetic outflow in hypertension after renal denervation is shown in this case report from Schleich in the New England Journal of Medicine. And MSNA in the title is muscle sympathetic nervous activity. What you see at baseline, a 55-year-old male on 7 hypertension medications. On the left is the actual muscle sympathetic nervous activity. The number of bursts per minute is shown to the right, 56 bursts per minute. Blood pressure 161/107. And then 1 month post-renal denervation, you can see now that the number of bursts has been reduced by 27%. It's now 41 bursts per minute. And blood pressure now 141/90. And 12 months post-renal denervation, one can visually see that the amount of sympathetic nervous activity is substantially decreased. And the number of bursts per minute is now only 19, which is a reduction of 66%. And blood pressure is now normal at 127/81 mmHg. This was accompanied by a significant and substantial reduction in both kidney and whole body norepinephrine spillover at 30 days, which really does reinforce the fact that there has been inhibition of sympathetic nervous activity associated with a significant drop in blood pressure. Now, about beginning in the 10 to 15 years ago, were multiple unblinded trials that showed that renal denervation lowered blood pressure. On the x-axis is the mean decrease in office systolic blood pressure at 6 months. And what you can see on an average is that many or most of these, in fact, all of them, had a reduction in blood pressure from 20 to 35 millimeters of mercury, which is huge. And then using a number of other catheters, Medtronic catheters, again, we see reductions in blood pressure of 20 to 30 millimeters of mercury. And this, the magnitude of the reduction is simply enormous. And I want to emphasize that if this holds up or held up in other randomized trials, this would have an enormous impact on the epidemiology of hypertension and its side effects. Now, this then led to a number of trials called the Simplicity trials, using a catheter, a Medtronic catheter. Shown up above is Simplicity 1. This was one of the earlier trials. There was only one arm to this trial. It wasn't randomized. And if you look at denervation in the top of the graph, you'll see a reduction of about 25 millimeters of mercury. Simplicity 2 was a randomized trial of denervation versus unblinded controls, but there was no sham procedure. And what you see there is 30 millimeter drop in blood pressure in the denervation arm and no fall in blood pressure in the unblinded controls. And then we come to Simplicity Hypertension 3. And when I first saw the data from this trial, I couldn't, there was a silence in the room because this was not what we expected. And what Simplicity Hypertension 3 showed was about a 12 millimeter drop in the denervation arm, but in the sham controls, there was about an 11 millimeter drop and no difference, significant difference in the two arms. So what really made the difference between these trials, or accounted for the difference, was in unblinded controls, there was no change in blood pressure at all. But in patients undergoing a sham control procedure, there was an 11 millimeter drop and no significant difference between the two arms. And I think the FDA in the United States deserve an enormous amount of credit for insisting that prior to renal denervation being approved as a clinical procedure, it would need to be demonstrated in a sham control trial. Well, the impact of Simplicity Hypertension 3 was enormous. And this is a graph developed by the late Sabu Ramtula on the natural history of evolving therapies. On the left is progress. You then get excitement or euphoria. Then there's a reality check. And then that's followed by a period of depression. And then things fall into perspective. And that's exactly what has happened with renal denervation. It was almost too good to be true that this technique could really reliably reduce blood pressures by 30 millimeters of mercury. And we've now had a reality check. Some people probably on Prozac, but others are placing it into perspective. And the perspective is that the initial enthusiasm has been tempered. And the number of unanswered questions is increasing. And that was the situation after Simplicity Hypertension 3. But nonetheless, the concept remains of interest. Now, the explanations for the Simplicity Hypertension 3 outcomes are multiple. Was it the wrong catheter? Were the operators inexperienced? That is being one criticism. The other is the power of the placebo, the Hawthorne effect, regression to the mean, drug adherence, the fact that many of these patients were on drugs, so there were a confounding effect, ambulatory versus office blood pressure. And I think, though, a general acceptance that technical issues may be important and need to be addressed. And these are, and that refers to the box on the left of the graph. Suffice it to say, and I'm not going to go through this in detail in the interest of time, but suffice it to say that there was a placebo effect. There was a reverse Hawthorne effect in that in one of the trials which showed no change at all in blood pressure in the control arm, this may have been that the patients actually didn't take their drugs because they were told at the end of 6 months, if their blood pressure wasn't controlled, they could get denervation, and they wanted denervation. So that may have been a reverse Hawthorne effect. Regression to the mean is something we've documented in a number of papers, and drug adherence. Many of these patients were on other drugs, and that may have been a confounder. I want to show you an example of the power of the placebo. Now, vasovagal or cardioinhibitory syncope involves the brain, amongst other organs. And there were a number of trials that compared pacing to no pacing in patients with vasovagal or cardioinhibitory syncope. And those are 4 trials shown on the left. And if you look at the mean in orange, the actual reduction in recurrent syncope, it was huge. It was about 0.08 was the odds ratio, which was a 92% reduction in recurrent syncope. Confidence limits 0.03 and 0.024, which is a huge benefit. But then there were 2 trials that looked at the potential placebo effect. And both groups of patients were given pacemakers, but they were blinded as to whether the pacemaker was activated or not. And now look at the results. You see that there was no significant difference between treatment and control. And in fact, the odds ratio was 1.49, I think, which was actually an increase in 1.49, which actually favored the control and as opposed to treatment. So here is an example of really the powerful impact of the placebo in patients undergoing procedures. In terms of technical issues, this is probably important. The earlier trial, Simplicity trials, were confined to proximal renal denervation. And if you look at the distribution of nerves in this paper from Mahfouz and Alusha, what you can see is proximally, if you look at the nerve distribution shown in green, it really does look as though there's a greater distribution of renal nerves proximally and not distally. And by proximally, I mean proximally in the renal artery as opposed to distally. But if I blow this up further, what you see, if you just look at the area adjacent to where the catheter is, which is that pale area in the center, what you see is that in fact, if you just look at those nerves adjacent to the catheter, you see a much denser distribution distally than proximally. I think 32% versus 76% in the laterally and 44% versus 63%. So this really raised the question about whether the next trials should in fact utilize both proximal and distal renal denervation. And in this study, not a trial, of 25 patients with resistant hypertension, there was a comparison. If you just look at ambulatory blood pressures, both systolic and diastolic, in yellow is main artery ablation, and in orange is combined main or proximal and distal. And you see a much greater lowering of blood pressure with combined ablation. The other issue relates to patient selection in the Simplicity hypertension trials. Many of these were older patients with refractory hypertension. And this is a comparison, a study which compares renal artery denervation's effect on blood pressure in patients with combined hypertension in yellow. Now, what do I mean by combined hypertension? That is systolic and diastolic hypertension. And the orange is isolated systolic hypertension. And isolated systolic hypertension is probably related to stiff vessels and older patients. And I suspect that if you have a stiff vessel as the cause of hypertension, you can denervate until the cows come home and it's not going to make any difference. And this study certainly shows that the magnitude of reduction in blood pressure in yellow was greater in those with combined versus isolated systolic hypertension. And this is important because in the next reiteration of the trials, which I'll show you, people with isolated systolic hypertension were by and large excluded. The predominant hypertensive subtype in elderly patients is isolated systolic hypertension, which is characteristic of increased aortic stiffness. And this correlates with age. And if you look at renal norepinephrine spillover in this trial from this study from ESLA, you can see that on the left, in patients with essential hypertension versus normals, there's much more norepinephrine spillover in those aged 20 to 39, 40 to 59 than 60 to 69, to 79. So what does that mean? It means that in younger patients with increased renal norepinephrine spillover, you would expect a greater response to renal denervation because this is a marker of increased sympathetic activity, whereas in older people with stiff vessels, there's very little increase in renal norepinephrine spillover. So this complements other studies that have suggested that renal sympathetic nervous activity is increased in young adults with essential hypertension. So there have been subsequently 3 trials. Spiral, I chaired the Data Safety Monitoring Board of this trial, and I'm well aware of the trial and the details. And in Spiral, this is Spiral off, which is patients in whom the trial was performed off medicines. And that is after a period of washout. And what you see is a significant reduction in blood pressure, 5.5 in baseline, I beg your pardon, 5.5 drop in ambulatory systolic blood pressure. In the denervation arm, 0.5 in the control arm, and this was statistically significant. Baseline pressures were the same in both arms. Now, this is from the Spiral on-treatment trial, 9-millimeter reduction with renal denervation versus 1.6 millimeters in control, 7.4 delta, which was highly significant. And then another trial using, this is the Radiant Solo trial, which used an ultrasound-guided form of renal denervation. And this is daytime ambulatory blood pressure as opposed to 24-hour ambulatory blood pressure. And again, a significant difference of 6.3 millimeters of mercury. So these 3 trials, all significant statistically, unlike Simplicity Hypertension 3, when there was no significant difference. Now, I would emphasize that all of these trials had a sham arm, so the placebo effect was excluded. And I think this reflects better techniques, newer catheters, a number of other improvements based upon what we learned from the Simplicity Hypertension trial, Simplicity Hypertension 3. People with isolated systolic hypertension were excluded from these trials. Another from Spiral Hypertension off med. What you can see in yellow is baseline, and in orange is at 3 months in the denervation arm on the left, and sham controls significant, statistically significant difference. And this is again from the Spiral trial off meds. And here's a problem. If you look at renal denervation on the left and sham control on the right, and the yellow, which is non-responders, what you see is that a significant number of patients, both in the treated arm and in the sham control arm, were non-responders. And I think it's in the treatment arm, 28% were non-responders. and in the control arm, 52%. And then if you look at the orange, which is responders, you see that in the sham control arm, there were a significant number of responders. And this is a problem, and I will come back to that just at the end of this presentation. The other question that's been raised is really this. If you look at changes in blood pressure, what you see on the right is the spiral trial, and on the left is the reduction in blood pressure, both systolic in yellow and diastolic in orange, with ARBs, beta blockers, hydrochlorothiazide. And if one looks at the right with the spiral trial, one can see that the reduction in blood pressure achieved is a pretty well equivalent to hydrochlorothiazide. And one of the questions that's got to be answered is how much does the fact that the trials were statistically significant, but how much does this add to our therapeutic armamentarium? And that question has been raised by Dr. Franz Messerli in this recent paper, where again, he says, talks about the study, which is the Radiant Solo trial, that shattered the halo. On the left is the reduction in systolic blood pressures in yellow and diastolic blood pressures in orange with ARBs, ACE inhibitors, beta blockers, calcium channel blockers, and hydrochlorothiazide. And on the right is the reduction in blood pressures in the Radiance trial at 3 months, and then the Radiance trial at 12 months with the circle around it, and then a meta-analysis of 6 randomized trials. And if you really look at this, what it shows is that the reduction in blood pressure at 12 months is substantially less than at 3 months, and really raises the question about what is going to be the role of renal denervation. And what they state is that they raised some questions about this earlier on, and they say, again, they're raising questions about the durability of renal denervation, but they still state, by all means, let's not close the book on renal denervation. And they argue about a trial of renal denervation for primary prevention of atrial fibrillation. Interesting thought. I'm not sure how feasible that trial would be, but an interesting thought. So I think pivotal keys to the clinical future of renal denervation is this. We have to identify responders from non-responders. I mean, there are people that had 40 millimeter drops in blood pressure and others that had no drop at all. One of the problems we have is there's no way to assess procedural efficacy. Now, with an angiogram or with a stent, we can assess angiographic success. There's no way we can assess acutely at the time of the procedure whether a renal denervation has been effective. The duration of efficacy is incredibly important because maybe the nerves re-innovate. And that's why in the Radiance trial of ultrasound-guided denervation, there doesn't appear to be the same effect at 12 months as there was at 3 months. And we really need to understand better who will and who will not benefit. And then I think the other question is, how much of a blood pressure reduction is enough? Is 5 millimeters enough? Does it need to be 10? Does it need to be 20? I think that's still a question. And then we really still do not understand exactly the mechanisms of benefit. I think it is related to sympathetic tone, but we need to understand that better. So what are the next steps? I think prior levels of achieved denervation are probably suboptimal. This is excluding the recent spiral trials where I think there was an adequate level of denervation. But so some of the next steps are to look at electrodes that deliver more energy, cryo-energy, alcohol ablation, which is chemical on the right. Testing for the durability of the efficacy of renal denervation. There are many ways of going about this. Norepinephrine spillover as a marker of sympathetic tone is the most practical, is the most accurate, but it's impractical. It's a laboratory test. Cannot be just done in the cath lab routinely. And then there are a number of other endpoints that are currently being studied, measurements of renal blood flow, baroreflex sensitivity, reflex solicitation. In other words, if you stimulate at a particular point and you find that this increases blood pressure, maybe that is a point in the artery where you should denervate. All of these are investigational. And then again, to repeat, identifiers of specific patient subsets to optimize the rate of responders. Hypertension has variable pathophysiology. Increased sympathetic nervous system activation is one, increased arterial stiffness is the other, increased volume overload. Some will respond and some will not. And I'm still struck by the fact that there is this huge effect in some patients and none in others, but we also see a real benefit in sham control patients that we don't understand very well, and determining mechanisms of blood pressure reduction. Dr. Maurice Brown in the UK made this comment: resistant hypertension or resistance to treatment or resistance to taking treatment. And this is a very sobering analysis, which from a number of trials, of drug trials, what you see in orange is total non-adherence, and in yellow, partial non-adherence. And what you see is somewhere around about 2/3 of people with hypertension do not take their drugs, or if they do, not regularly. And I still wonder about that first case report I showed you of the patient on 7 drugs who then responded so dramatically to renal denervation. I wonder if it was once the patient got denervated, the patient also was more rigorously followed and stayed on their drug therapy. If I see someone is on 4 or more drugs and they have it has no effect on their blood pressure, I'm almost convinced that they're not taking their drugs. And one of the things I really don't understand is when you look at hypertension and the effects it has on heart failure and stroke and vascular disease, why would someone who's hypertensive not take their drugs? But it's a fact. Everett Koop, the US Surgeon General from 20 years ago, made this profound statement: drugs do not work in patients who do not take them. And I think we always need to keep this in mind when we assess a patient. Are they taking their drugs? Our last slide is from Mark Twain. He was sitting in London having breakfast, reading the newspapers from the United States, and he read his own obituary, which had been mistakenly published. And he sent off a cable: the reports of my death are greatly exaggerated. So I think that there is, in the case of renal denervation, the reports of its demise were greatly exaggerated. I think there's some evidence of a resurrection with the 3 most recent trials that there is a statistically significant reduction in blood pressure with this technology. I think we may see further improvements. I think some of the huge questions that still remain to be answered: how can we identify responders? How do we assess the durability of the response? Which subsets are likely to benefit? And we need to understand better some of the mechanisms. So I think that there are still many questions, but at least some answers in that the technique does work. Thank you.